The progress in treating acquired resistance really comes in two forms. So one is the rather obvious, but until recently relatively poorly recognized fact that progression within the brain most likely actually represents failure of delivery of the drug to the brain as opposed to the cancer formally adapting. And that's a challenge to the pharmaceutical industry to not only make drugs which have potentially greater potency and greater penetration into the brain, but it's a challenge to the clinical academics to design clinical trials to effectively assess activity in the brain. And we're starting to see that, particularly in things like ALK-positive lung cancer and EGFR-positive lung cancer, where people are starting to design small CNS-specific trials, and I think that's the way the field will be going. The other area is when the cancer is growing outside the central nervous system. And what's happening there is the cancer is adapting and specific resistant clones are being selected out. Rebiopsy of the cancer has really informed us a lot in terms of the different mechanisms of resistance. The two dominant ones are you essentially just turn back on the same signaling pathway, you adapt it to fire in the presence of the drug by making more of it or mutating it, or you say, okay, that pathway is shut down by the drug. If I'm the cancer, what I'm going to do is dial up some other pathway, so a bypass track. And we've certainly, I think, made more progress with the former of those, so making more potent drugs, screening drugs against some of the resistance mutations has allowed us to produce second and third generation drugs. For example, in EGFR mutant lung cancer, the third generation drugs work against T790M, a common resistance mechanism. And in ALK, many of the second generation drugs have activity against a whole range of ALK resistance mutations. In terms of bypass tracks, that's a harder one, because now you probably have to combine two different drugs, and so you really need to know what's going on. Whilst it's easy to look at the original pathway that you were interested in and see how it's changed, for a bypass track you have all of the possible oncogenes out there to go and look for. And we have to develop the predictive biomarkers to decide who we should combine this drug with or that drug with.